All right, let's dive straight into this explainer and discover how seemingly routine activities of daily living are actually high-stakes, life-or-death clinical interventions. Seriously, if you've ever thought of patient hygiene, dressing, or feeding as simple comfort measures, you're about to see them in a completely different light. What we're actually looking at here are the foundational pillars of a patient's physiological integrity. Here is our agenda for today. 1. The stakes of basic care. 2. Bathing and grooming safety. 3. Dressing neurological deficits. 4. Feeding and airway protection. 5. Toileting and infection control. And finally, 6. Oral care for vulnerable patients.
Section 1. The stakes of basic care. Let's go ahead and shatter a major misconception right out of the gate. It's wild to think about the sheer contrast between how mundane these tasks might seem to the average person and the absolutely devastating consequences of doing them incorrectly. Professional nursing exams like the NCLEX demand that we view all of these activities through a lens of absolute safety. We aren't just washing away dirt, right? We are actively controlling colonizing bacterial loads, we're preventing skin breakdown, and we're implementing evidence-based interventions to preserve a patient's functional independence. So what looks like routine care is actually highly complex clinical judgment in disguise.
Moving right along to Section 2, Bathing and Grooming Safety.
Let's talk about the physical interventions at the bedside. To prevent cross-contamination, you absolutely must follow a strict anatomical hierarchy. It's all about moving from cleanest to dirtiest. You always start with the eyes, carefully wiping from the inner canthus to the outer canthus using a fresh section of the washcloth. Why? Because you do not want to transfer pathogens into those lacrimal ducts. Then you wash the face with plain water so you don't dry out their skin, followed by the arms and trunk using long, distal to proximal strokes to promote venous return. You always end with the perineal area. But as you work your way down to those lower extremities, there is a massive red flag you have to watch out for.
Listen up, because this is absolutely crucial and a huge NCLEX alert. Vigorously rubbing the lower extremities could literally cost a patient their life. If your patient is on prolonged bed rest, they are at an incredibly high risk for a deep vein thrombosis, or DVT. If you apply deep friction or massage to those calves during a bath, you can easily dislodge that hidden thrombus. And if that clot travels straight to the lungs, that's a fatal pulmonary embolism. Always, always wash those legs with gentle, smooth strokes. As we shift from bathing to grooming, we hit another area of extreme caution. Nail and foot care for vascularly compromised clients is strictly off limits. Think about your patients with diabetes mellitus or peripheral arterial disease. Because of diminished blood flow and neuropathy, a tiny little microabrasion from a nail clipper can evolve into a non-healing ulcer and eventually a full-blown amputation. You never cut their nails. Leave that to a podiatrist, for sure. You also never soak their feet, because that macerates and breaks down the tissue, giving bacteria an easy entry point. Oh, and never apply lotion between the toes. All that trapped moisture just invites fungal overgrowth, like tinea pedis.
Section 3. Dressing neurological deficits. Let's talk about the physical dexterity required here, especially for stroke patients who suffered a tremendous loss of function. I want you to burn this mnemonic into your brain: DAF and USA. It perfectly maps out how to dress patients with unilateral weakness without accidentally hyperextending their compromised joints. When you're putting clothes on, you dress the affected side first, DAF. The weak limb can't actively maneuver, so by dressing it first, you can manipulate the clothing over that immobile joint without stretching it. Then they can use their strong side to finish up. When taking clothes off, you undress the strong side away first, USA. Getting the garment off the functional limb first creates a ton of slack, which lets the fabric just slip effortlessly off the paralyzed limb without straining it. It's honestly a brilliant biomechanical hack. Section 4. Feeding and airway protection. This is where promoting a patient's independence collides with severe respiratory risk. Before we even offer a single bite of food, we've got to assess our patient's alert status and rule out hidden signs of dysphagia, which is difficulty swallowing. Say your patient has Parkinson's, advanced dementia, or just had a stroke. Their swallow reflex might be severely compromised. You have to actively look for red flags. Are they pocketing food in their cheeks? Do they have a wet, gurgling sound to their voice after swallowing? Are they clearing their throat a lot? If we miss these subtle signs, food or fluid is going to enter the tracheobronchial tree, and that leads straight to aspiration pneumonia and potentially death. So how do we mitigate that risk?
Well, speech-language pathologists prescribe very exact dietary modifications. Regular, thin liquids just move way too fast for a compromised swallow to safely manage. So we alter the viscosity. Nectar-thick fluid pours easily, kind of like apricot nectar. Honey-thick pours a bit more slowly. And pudding-thick is so dense it holds its shape on a spoon. These specific textures are absolute game changers because they buy the patient's swallowing muscles the precious time they need to coordinate safely. But texture is really only half the battle. Positioning is everything. To protect that airway, the patient must be sitting bolt upright at 90 degrees, what we call the high Fowler's position, and they need to stay there for 30 to 60 minutes after the meal to let gravity assist with gastric emptying. On top of that, you instruct them to use the chin tuck method. It's so simple but so effective. Just tilting the chin down to the chest mechanically pushes the epiglottis backward. That closes off the trachea and opens up the esophagus, making sure the food bolus safely enters the stomach instead of the lungs.
All right, let's jump to Section 5, Toileting and Infection Control. Toileting is actually one of the most common precipitants of patient falls in severe preventable hospital infections because the urgent need to use the bathroom causes so many unassisted, impulsive transfers that lead to falls. We have to anticipate needs through proactive hourly rounding. But once the patient is voiding, our total focus shifts to infection control. For female perineal care, always wiping front to back is the exact physical action required to prevent a healthcare-associated urinary tract infection, or HAUTI. By positioning the patient in a dorsal recumbent position and strictly wiping from the pubic symphysis back toward the anus, you're preventing the translocation of E. coli and coliform bacteria from the perianal region right into the urethra.
Now, here's an alert that you cannot afford to forget, because missing this one simple step during male perineal care creates an absolute medical emergency. When cleansing an uncircumcised male, you obviously must retract the foreskin to clean the underlying glands. But the critical safety constraint here is that you must immediately replace that foreskin back to its normal anatomical position. If you leave it retracted, it acts exactly like a tourniquet. It forms a tight, constricting band that blocks venous drainage, creating a very dangerous condition called paraphimosis. Ischemia and tissue necrosis will rapidly set in, eventually leading to gangrene of the penis. So please, keep this massive safety alert in mind.
And our final section, number 6, Oral Care for Vulnerable Patients. This is a vital comfort measure that directly impacts systemic cardiovascular and respiratory health. Neglecting the oral cavity allows highly pathogenic biofilms to accumulate. Now, for a healthy person, that just means dental decay, but for an unconscious client, it's literally a matter of life and death. Because unconscious patients lack a protective swallow or cough reflex, this specific protocol uses gravity and suction to prevent fluid from pooling in the pharynx and entering the lungs. First, you place them in a lateral, side-lying position, facing you, with the head of the bed elevated at least 30 degrees. You must have that wall suction on and verified before you even start. Gently open the mouth with a padded tongue blade, never your fingers, okay? Because a primitive biting reflex can cause severe injury to you. And a quick side note, never use oil-based moisturizers like petroleum jelly on their lips, as that carries a serious risk of lipid aspiration. Now, what about denture care? The crucial point here is purely preventative. A simple towel and an inch of water can save a highly expensive custom appliance from shattering into pieces. You see, dentures get incredibly slippery when they're brushed with soap or cleanser. If they slip out of your hands into a dry, hard porcelain sink, they will absolutely fracture. Setting up that simple cushion of water and cloth prevents thousands of dollars in damage. Oh, and also, never use hot water on dentures. It will permanently warp the plastic framework and completely ruin the custom fit. To bring it all together for this explainer, we've synthesized every major clinical action and safety constraint we've covered today into one powerful study tool. Just look at how every single category ties a seemingly basic task to a severe clinical risk. Bathing connects directly to DVT prevention. Grooming prevents diabetic amputations. Dressing requires biomechanical strategy to protect compromised joints. Feeding uses gravity in specific angles to prevent pneumonia. Toileting hinges entirely on spatial awareness to prevent deadly systemic infections. And oral care relies on positioning and suction to keep that airway clear. So I'll leave you with this provocative question, and I urge you to never look at basic care and comfort the same way ever again. Every time you wash a patient, dress them, or even just hand them a glass of water, you are executing complex, life-saving clinical judgments. You are quite literally the final line of defense between that patient and a fatal complication. If you keep these concepts front and center and master these constraints, you won't just pass your exams, you'll be an exceptionally safe, sharp clinician out there on the floor. Thanks so much for diving into this material with me.